Okay, the recording's on.
Okay, good afternoon, everybody, and I'd like to extend a thank you to the participants who have registered for today. We see people who signed up for our previous webinar as well as this advanced one, so we're very appreciative of that interest and for practitioners' care of our patients. We will send some information out via the association as to how people can register to see any of these sessions in the future. If there are people in your office who can't participate but would like to look at the archived sessions, and I think we keep those up for about 2 years. Yeah, 2 years since our communication people. Particularly, it may be important to say to physical therapy, we're assured by their association they sent the invitation out, but we're hearing from members that they may not have received it, so physical therapists for sure may be wanting to look at this in our archive in the days to come. I'd like to start by introducing our consultants. So Gord Chadwick is here next to me. Gord will be a presenter today. Dale Patura behind me will be another presenter today. So Gord is a chiropractic consultant, Dale a physical therapy consultant. Next we have Lex Greer, chiropractic consultant, and then David Katchen, who is our physical therapy consultant and works by remote out of province. So we will have Dale and Gord do the presentation today. We heard from Lex and David a few months ago. A couple reminders. First of all, if you're looking for our standards of care, the soft tissue guidelines, our forms, any information about WCB, do take a look at the WCB website under the Care Provider tab. We have all of that there for you, and we also have a resource manual for you as well. Also a reminder, when you have a worker present at your office who says they've had a work injury, you don't need to wait for authorization to treat. You simply send in your initial report form and begin treating, and if WCB isn't funding that treatment, they'll let you know. Pardon me. Otherwise, you should just proceed. So you're not delaying treatment, waiting for the authorization form to come back. You're not billing the client who may be ill-prepared to pay. You simply begin treatment. Then at the point where you're ready to start the second block of treatment, if WCB is still funding, you simply need to send in a progress report to indicate another block of treatment is planned. And if WCB doesn't indicate that they can't fund, you simply go ahead with that. So just trying to keep delays out of the treatment system. So with that, I'm going to introduce Gord and Dale then, who will give today's presentation. Thank you again for attending.
So for any of you who attended last time on our webinar, we discussed more of the basics about treating WCB clients. And we discussed, went through the case management of the different forms that WCB has. So today what we're going to do is we're going to just move on from there and try to continue along that same line and talk about some advanced case management strategies. So as we all know, just hit stop. And then we're all here because of problems that occur in the workplace, different injuries. So we thought we'd start with just this little bit of a video to talk to us about that. So, some pretty unique ways to get jobs done, that's for sure, but obviously not the safest ways, and typically or often creating injuries in the workplace. So what we want to do today is to talk more about how to manage these situations when they end up in your clinic. The objectives for today will be to give us a brief review of the summary of the soft tissue guidelines. Then we're going to go review and summarize the primary progress notes. Then we're going to have a discussion about the predictive factors for chronicity, summarize some of the key decision-making points in managing our work injuries, and then go through a few case examples. We'll certainly are more than open to questions. Probably will note that most of the questions will be answered as the presentation goes on. So just use your little chat feature there to send us any questions. If we'll see them come up on the screen, and if we have to answer them quickly, we can. Otherwise, we'll kind of batch them till the end of the presentation and then go through the questions at that point in time. So, our soft tissue guidelines, which we've all been trying to work around and understanding that these are definitely guidelines. These soft tissue guidelines, when we developed them, were based on the stages of soft tissue healing. We also was based on the research we did at the time regarding the best practices of soft tissue injuries. And at the present time, the WCB is currently, again, going through a process to revamp these soft tissue guidelines and to update them at this time. So, as a summary to this, the first 0 to 4 weeks, up to 10 interventions are allowed. These obviously don't include the initial assessment or any return to work planning or programming, and that was designed because that was, we felt, or we know, is one of the most important components of the treatment management. The 0 to 4 week mark tries to coincide with the acute and subacute stages of soft tissue injury, and research at this point indicates that there's minimal treatment necessary in this time frame. A large majority of the injuries just resolve, and the main focus of treatment needs to be on education and trying to return somebody back to their normal activities as soon as possible. Obviously safely, but in the WCB realm, work is part of that normal activity, and work is kind of a key guider to that return to normal activity. In the next stage of the soft tissue injuries, we allow up to 23 interventions. This stage now, which is from the 5 to 8 week mark, can include regional and functional conditioning and may include one functional abilities evaluation. That is to possibly start a return to work program if one can't be negotiated between the worker and the therapist or the treating practitioner, or sometimes the functional abilities evaluation is used to kind of convince the injured worker that they're doing better than they may think they are. Here's a good starting point for us, and we can move on from there. This stage of the soft tissue guidelines coincides with the subacute and remodeling stage, and the theory behind that is that if we need to, we'll increase the intervention at this time. That will allow for better tissue accommodation and help to avoid the significant secondary problems. Also allows us to condition that area for returning to normal activities, including work. Most of the information in the literature from our last review was on rehabilitation programs during this time frame. The last stage of the soft tissue guidelines outlines the 9 to 12 week mark. In this time frame, the suggestion again is up to 12 interventions. We're fully into the remodeling stage at this time and would be expecting that the injured worker is back to work or nearly completed their activities or their rehabilitation. And if they're not resolved, then we got to really be asking ourselves why. If they're not coming to the end of their treatment programming, then we would require assessment team review at this point in time. We just got a question in regards to soft tissue injuries and to define that, and we will certainly define that. We actually have a definition of that in the guidelines, in the soft tissue guidelines. So we'll get that specific definition up, and so that we're all talking the same language. So when we come to the primary progress reports, these primary progress reports are designed to track the progress of the injured worker. We try to incorporate the timing of these reports so that it's consistent in some aspect with the soft tissue guidelines, and also so that they're consistent with the internal workings of WCB when we do administrative review processes. So in regards to the physiotherapist's treatment progress notes are required after every 10 sessions, which is typically around the 3-week mark. If you look at 2 of those, that puts you into the 6-week mark or the 9-week mark, which is right around this time frame in regards to the administrative review process, as well as the time frame as we're moving from the first stage of soft tissue or the first soft tissue guideline phase into the second soft tissue guideline phase. The chiropractic reports are every 6 treatment sessions, and again, with the treatment frequencies, tends to put you in those timelines as well. The information on the reports is extremely important. We try to use that, and we consciously have developed those reports to look at some of the critical information that helps us decide the case management decisions. So the critical information that we're looking at is obviously the objective findings of the injured worker, the assessment of recovery score, the self-reported functional outcome measure scores, and the return to work status of that injured worker. So the objective findings give us an idea of how that injury is progressing. What is best and ideal when these reports are coming in is if there is quantitative and consistent information. The second point on this slide here says specific measures one report and mild, moderate, or severe description next, makes it difficult to compare. So oftentimes we'll see reports that say the client has 75% of normal range of motion of the cervical spine in rotation. And then the next report says cervical rotation is improving. And then maybe another report has there is moderate reduction of range of motion of the cervical spine. So trying to piece all that together and knowing that those are different definitions for different people makes it very difficult to understand, is that person's objective findings really progressing? So being more quantitative and definitely being consistent in your information from one report to the next really makes the case management easier from our end of things, reviewing the files as well as case management, but also from the practitioner's point of view to understand the progression of that injury. The assessment of recovery score. This is we put this in there as just kind of an understanding of how does the practitioner feel this is improving. So the practitioner's impression of improvement. The higher the number, 5, 6, 7, 8, 9, indicates that there's more progress in recovery as compared to what the anticipated pre-injury status would be. We understand that you don't know what that pre-injury status would be totally. We just understand your expertise as practitioners and your understanding of the injuries that you see, and realize that you'll have some feeling, some gut thought process of how this was, how bad this injury was, and where this injury is now in regards to progress. And that's what we're trying to get from you on this. So this is the objective findings are the what's happening with the pathology. The assessment of recovery score is what the practitioner feels is going on, or the practitioner's impression of improvement. The self-reported functional outcome measure then is the client, is the injured worker's perception of what's happening. Again, in this, to truly understand how this is progressing, we need to use the same numbering system. So if you're filling out a particular self-reported functional outcome measure, such as the DASH, and in the initial assessment you use a number, 89, and then in subsequent ones you use like 45% or 20%. Certainly you can do the math, but it's difficult to try and understand how that person is progressing. On your progress notes, please include the original number and the current number, because that just gives us a good look right there, a good snapshot of what's happening with that worker as each report comes in. Again, as indicated before, this indicates the worker's perception of the recovery. In the return to work, why are we asking for that? Because we know the research says that the quicker these people can get back to as near normal activities as possible, the better. Obviously, workers' compensation clients get injured in the workplace, and part of that, or the major responsibility, is trying to ensure that person until they recover back to the work activities. So we use work as an indication of a return to a type of normal activity. So the progress reports take into account the different components of the recovery. So the objective findings take into account the pathology, the pathology progression, or the improvement of that injury. The assessment of recovery score takes into practitioner's perception of the recovery, the assessment of recovery. The self-reported outcome measure takes in the injured worker's perception of recovery. And the return to work status then is a indicator of return to some level of normal activity status. So just before we move on, we'll talk about can you define soft tissue injuries? So the definition from this one's taken out of the primary chiropractic and physical therapy soft tissue treatment guidelines. So two definitions: soft tissue. Soft tissue includes muscles, tendons, fascia, and ligaments. A soft tissue injury is an injury to one or more soft tissue structures, including muscles, tendons, fascia, and ligaments that connect the skeletal structure. Soft tissue injuries generally include strains, sprains, and contusions. Soft tissues can also be injured as a result of direct trauma, overuse, overstretching, or whiplash-type injuries. So soft tissue injuries do not include direct or indirect trauma to bones, such as a fracture, nerves, carpal tunnel syndrome, neuropraxia, vascular, complex regional pain syndrome, or post-surgical soft tissue recovery. So part of the question also discussed where do the SAS spine pathway patterns fit in? Well, for sure, patterns 1 and 2, which are mechanical low back pain primarily, would be a soft tissue injury. Pattern 3, which is typically a herniated disc without significant neurological deficits or with recoverable neurological deficits, would also probably fit into under a soft tissue guide or a soft tissue. And pattern 4, which is a spinal stenosis, you would have to decide what the actual injury was to create that situation.
Now, there's a question with regards to what would you use for a functional questionnaire tool for the thoracic spine? Would you use a Roland Morris, or would you use an NDI for that, or what would you use for that? The identified and accepted, I guess term might be the accepted functional questionnaires that we have from WCB are the DASH, or the Quick DASH, the NDI, the Roland Morris, and then the lower extremity functional scale. So those are the ones that are accepted. So in that case, with the thoracic complaint, I guess you kind of make a clinical judgment to where it is, lower, upper, and decide if you want to use the NDI or the Roland Morris. If you come across a specific, I should back up. We're trying to definitely keep, we all know that there's tons of functional outcome measures out there. There's some that are really specific, some that aren't. And we're just trying to keep them corralled a little bit and try and use the same ones consistently over time, so that if we do try to use, or we do use this for research purposes, we have some consistency through that. I would, with regards to that, I agree with Dale. I think if there's some involvement of the neck, because oftentimes in a thoracic spine injury, you'll have some component of neck complaints at the time. So if they do have that, then I'd probably use both the NDI and the Roland Morris, which will give you a little bit of both of where they're perceiving their complaints are in the neck and also in the thoracic or lumbar spine. So I think I would use probably both of those if you feel that there is some neck involvement. So that's what I would do with that. So
when we move into the next stage of our presentation, predictive factors for chronicity, the point we'd like to make is that the progress notes that have been designed here were a combination of case management information required, objective and clinical information required, and also tried to ensure that we created a report that didn't
make the clinicians do a whole bunch of double work, extra work. They're designed to look at more than one factor. What we do know, and what you as clinicians will know who treat these clients every day, is that there's no silver bullet for prediction of whether this person's going to be a complicated case, going to be an easy situation, going to move on to more chronic pain. There is no silver bullet. There's a combination of things. So we tried to take a combination of things and put them into the progress notes to help us to progress to progress the case and help with the case management, both from the WCB point of view as well as the clinician's point of view. So when we talk about those predictive factors, Gord's going to move into now a little bit more of the current research as it relates to those different factors.
So when we make decisions here at WCB, we take into consideration what the research says, and to develop some type of policy, how we develop our forms, what we need to have to make decisions on management. So looking at the research, we know that low back pain is one of the major causes of WCB, time loss, and disability claims. So that's clear across the world. I mean, this has been for a long period of time. But there are critical components and critical times when we need to sort of analyze when we need to review the case and what we need to do to intervene sometimes and go to more complex treatment plan. And we know from the research in Quebec Task Force is that the critical component timeline is between 3 and 12 weeks post-onset of the injury. And at that point, we need to sort of look at, okay, is this person progressing? And we're going to talk about all of that as we go along in the program. So we know that less than 50% of individuals with chronic low back pain who missed work for greater than 12 weeks actually returned to work. This is from Spitzer in 1987. And we know that a delay in rehabilitation will end up resulting in, if you're off for more than 2 years, not on employment and you're not back to work, that you have basically no chance of returning to work. So it's critical that we actually be able to get the right treatment plan at the right time. So what are the predictors of disability? So what does the research tell us at the present time? Well, for successful rehabilitation, it's amazing how little research is out there to say, well, who would be successful? Okay. Yeah, I think you... Just hold on for a second. We just have to get... There we go. This research by Van Hoof was basically showed that if you had low back pain and it was chronic low back pain and you were mild to moderately disabled, that they compared staying in a rehab center and just having it in a rehab center, your work conditioning, or whether you introduced people into the workplace and did part of your work conditioning in the workplace, that those who were mild to moderately disabled did better when you introduced them into the workplace versus just keeping them and doing work hardening in a rehabilitation center. So when we think about how we push all the time to get people back to work, the research clearly shows that if we get them back to work at the same time we're trying to do work conditioning and work hardening, that we're much more successful, especially with chronic low back pain.
Yeah, send it just to Pat, though. Yep. Just to let them know we're trying to work on the echo, I just need to know if the volume is mumbled or too loud.
So is the volume, is the echo too high or too low? some people are saying that there's a bit of an echo.
Okay, so one is good, one is not.
Yeah, see,
So I'm not having, well, so it might be a computer too,
yeah.
that you may be getting an echo from, because some people are not finding an
We
echo.
need to advise if you've got their phone and computer on to turn the phone off.
He's all right.
Yeah.
Do you want to repeat that, Gord?
Yeah.
So if you have your phone, you should make sure your phone is off and you're just listening to your computer. Either or,
Not both.
but not both. Because if you have both, you'll get an echo both from your phone and the computer. So you either got to listen to the phone or your computer, but not both, okay? So what are predictors for unsuccessful rehabilitation? There's much more research to show what's not successful. And this research paper was from European Journal of Spine, and it showed that people who had high intensity scores had poor outcome in rehabilitation and return to work. The patient's perception about whether their back pain will persist over a long period of time has shown. So somebody coming in to you and saying that, you know what, I think my back pain is quite severe, it could last a long period of time, it's just not going to get better. That's a red flag, and you need to sort of say, okay, well, that's interesting, and then look at other factors. So that's clear within the research itself. The level of pain intensity and disability perceived by the injured worker also is a predictor for unsuccessful rehabilitation. So I have high pain scores, high pain intensity, it doesn't seem to change. You're treating them and it remains high. And when you're talking to them and you're saying, well, how are you doing at home and everything, and in the return, oh, I just feel like I can't do anything that I used to, I can't do anything at home. So their pain complaints and their perception of their disability is high, even as you're treating them and you're seeing them functionally get better. So other predictors are depression and anxiety. That's a big one. So you've got to be concerned. Are they're feeling depressed? Are they very anxious? Do they have a fear avoidance? They don't want to do anything because basically they feel that they're going to increase their back pain or they're going to make the problem worse. Passive coping has shown to be a predictor for unsuccessful rehabilitation. So somebody who basically says you give them a home exercise program or conditioning program, and then you find that basically they want to come to you for treatment, but they're not really doing anything actively at home, and they're relying on you to basically cure their problem. So they have a poor coping capability, and it's more passive, allowing somebody else to take control of the problem. Catastrophizing. So this is the worst problem I've ever had. I don't think I'm ever going to be better, and that becomes a problem. So education, somebody who's older, male, poor education has a less chance of a successful rehabilitation. Somebody who has a high BMI and is physically inactive, also in the research has shown that it's that they can have an unsuccessful rehabilitation, or they don't do as well under treatment. So we've looked at the research, and the research clearly shows some of the major things, and some of those that we see, and when we do the multidisciplinary assessments, is that a lot of them have a high anxiety. They're very anxious. They have depression. They're obese. They're very inactive. And so this is something to sort of just pull that together as to the stress level sometimes the workers feel. So you don't have to be a parent just to be stressed out. You could be a parent and an injured worker, and that's enough to basically have a bit of an anxiety disorder in itself. So this was a very interesting study and was presented at the North American Spine Society, and this shows Smuck and Associates showed that physical activity and a lack of activity and high BMI has a higher risk of back pain. A lot of the research up to now is that we've felt that obesity has some type of relationship to back pain and to poor recovery with rehabilitation, but interestingly enough, there hasn't been a lot of research out there to actually show that. This is a study that looked at both activity levels and the incidence of back pain with people who have high BMI. So the risk of lower back pain doubles for those who are overweight. So if you're just generally overweight, you have a 2 times chance that you're going to have back pain. Adults that are extremely obese are 4 times likely to have low back pain. So the client coming in, they're generally severely obese. They're 4 times likely to have a low back problem, and we know that the incidence of low back pain, the incidence of obesity in itself in North America has increased significantly, and in Canada 200% since 1980s. Yeah.
Cool.
So how can we help this? Like, how can we affect the obesity part of when somebody's coming in? And oftentimes it's hard to get them to want to do activity because oftentimes they're very inactive. They haven't really done much. So this paper really shows that 20 minutes of moderate exercise lowers the risk of back pain by 17%. So it doesn't necessarily impact at the present time that you're trying to rehabilitate them, but if we're looking at trying to keep this person in the workplace and not having further back pain or further back injuries, that we can say, listen, the research clearly shows that if you just do 20 minutes of moderate exercise, that your risk of back pain would be decreased by 17%. Overweight adults who add 20 minutes of moderate activity each day can reduce the risk of back pain by 32%. And people that are severely obese, if you add 1 minute to the exercise program, so you go from 20 minutes to 21 minutes, the actually percentage of decreased risk of back pain goes up to 36%. So this study won the award at the North American Spine Society conference because it really shows the relationship between obesity, back pain, and activity showing positive impact on decreasing back pain itself. So this is a very interesting study. So we see all these risk factors, and we know that back pain, if you have chronic low back pain, if this is your second injury or third injury for neck or low back pain, that you have a higher incidence of comorbid conditions. And for low back pain, you can have more problems with respiratory problems, irritable bowel syndrome. You have more chance of getting chronic pain condition syndrome with it, and you have higher incidence of having more anxiety and depression. So this person comes in and you see that it's the third or fourth injury that they've had and of neck or back problems. You have to then in the history find out what other comorbid conditions that they have, and because that will oftentimes impact how well they do in rehabilitation. So when we're looking at primary care, not one factor can determine whether the injured worker will make a successful recovery. So we're not just saying, okay, you find one factor and therefore you need to jump to a secondary or tertiary assessment or there's all these red flags. But it's the combination of taking the case history and seeing what the objective findings are and doing your functional questionnaires. And when you're doing the reports and you're doing your examination, and you have to constantly ask yourself, you know, where do I put this person? Are they a pretty simple, straightforward case, which would be an intensity of 0, or are they a high-risk type of case that would be more of a 1? And just putting the 1 down sort of intuitively to you makes you look at each CHP or each week that goes by, how is this person actually doing? So it's amazing in our in the physio reports and the car reports how many people don't even fill in that, whether it's a 0 or 1, and sometimes they don't even put in where their recovery rate is. Well, that's important when we're trying to look at this and trying to determine, are we going in the right direction or not? So recognizing that every injury is unique, everybody should be taken as the individual, and we need to look at their global physical problem and their psychosocial profile, and early identification of potential factors which may derail a treatment plan. And we know by the research, if we don't intervene soon enough, and if these prolong, the person's chance of going back to work becomes less. And that becomes whether they don't like their job or whether they're having family problems, and now it's easier to stay at home. They have children, and they need to, you're finding that it's much easier if they're at home looking after their children. So there's many factors in this. So developing a management plan to suit the individual and not having the individual fit a canned treatment program. And we see this sometimes in certain clinics and certain rehab centers, that no matter who goes in, they get the same treatment plan, whether they're a high intensity or a low intensity case. And we want people to say, no, you've got to individualize that program to that person's needs. So, based on what the research shows, we're going to look at different areas. And I'm just going to summarize what some of the research shows if we look at the different components with regards to, okay, we're looking at the work. So specifically with a work profile, males who are 50 to 60 or older have a higher incidence of not doing well in rehabilitation, and both primary and a functional program. Multiple jobs not lasting 1 to 2 years. So they jump from job to job. This is their 4th job in 3 years. So that's a bit of a flag. So you're just sort of in your mind or ticking out in your notes saying, you know, there's some factors here. Injury first 6 months of employment. Look how many cases we see where somebody is in their first month of employment and all of a sudden gets injured. Job satisfaction. We don't have this on the progress reports, but this is a very interesting sort of exercise to do with your injured worker on day 1, is to ask them, well, how would you rate from 0 to 10 your job satisfaction? 0 being, I just hate my job, like I don't like it, I don't like the people, I don't like doing it, to 10 out of 10 saying, oh, I just love my job, this is the best job in the world. So we don't have that on any of our reports, but it's a good thing for you to put down to sort of say, you know what, this person put down 3 as a job satisfaction. In itself, it's not important, but combined with all the other factors, it may take you to a place of showing that that person might have a higher tendency for disability. Now, on the other side, when we see cases that somebody says they're 10 out of 10, that's a red flag too, or a yellow flag. Because, I mean, lots of times I don't even like a 10 out of 10. I can say my job is the best. So when I see that and somebody says, oh no, this is the perfect job, it's the best thing, but this is my 10th injury, you know, then you start to go, okay, well, this could be a little bit over the top. So low, super high, and the relationship of that. So, and then you just talk, you know, about, well, how's your relationship with your employer and your employees? And if you don't ask the question, you're not going to find out whether it's poor or they love it, or they've just had their employer has said that he's not, in the last 6 months, that he's not really performing his job properly, or conversely, he has a fellow worker that basically he has to work with, really they don't get along at all. So another red flag is no modified duties. Or he's failed to return to work on 2 occasions. You've tried to get him back to work. He's lasted 2 weeks, and then he's failed again. Then you've modified, thinking functionally he's doing quite well or better. I think he can go back to work, and then he again fails again. So not one of these factors is the key to all of a sudden, get excited about what you need to do next. But again, it takes into the workplace. These are the questions you should be asking yourself. So physical, well, in pain intensity scores, we know from the research, and there's been numerous research articles on this, that high pain intensity scores that don't change is definitely a yellow flag. Outcome measures score high. We see this, and I'm going to talk about a case that clearly showed this, that the functional questionnaires didn't change. Matter of fact, they got worse as the treatment plan and the program, the management plan went along. The physical findings do not match the pain intensity. So, in fact, you're not finding any neurological problems. You're only finding restricted range of motion, but some biomechanical problems. But the pain intensity still continues to be 8 or 9 out of 10, and their perception of what they can do is severe, and they're not functioning at home. Yet you're not finding that on the physical findings. They have positive Waddell signs. Response to treatment is highly variable, and this often happens because we all get caught in this, is that oftentimes we'll treat them, they get a little bit better, and then you go along and you're thinking, okay, I'm going in the right direction, and then all of a sudden they come back 2 weeks and they're back. They're down again. And then you treat them, you change your treatment plan a bit, they get a little bit better, and then 2 weeks from there, they drop down again. So it's this variability to the treatment. If you feel that they should be progressing and there hasn't been any changes to their environment, both at home or in possibly in their graduated return to work, then why is this so variable? And we need to sort of put that aside. Obesity and physical inactivity, we know this. The research now shows that there's a link to that in doing poorly in primary or functional rehab, and multiple comorbid health issues. I mean, they're diabetic, they have depression. You just add it up and you just look at it, and there's about 6 or 7 comorbid conditions, and plus you're seeing some work issues and everything else, and you have to ask yourself, can I really handle this? If all of a sudden you're seeing very slow progress and plateau, and a lot of barriers being put up by the injured worker. And then activities of daily living. We talked about this, catastrophizing. This is just a horrible thing. It's really affected. My kids have to do all my activities at home. And this is a mechanical grade 2 back pain, yet they can't do anything. Their neighbor comes over, their daughter's now living at home and looking after the job duties. Personal relationships. Oftentimes they're coming from problems with personal relationships with regards to their family or their spouse, and the injury now just magnifies this. And so asking how's everything at home, and do you have you can't ask, well, how are you doing with your spouse? You can say that, but oftentimes it's saying, do you have a good support system at home? Like, are you getting support from your kids? Are you getting support from, and oftentimes that opens the door for them to say, my spouse and I are just having a tough time, and my kids, are on drugs and blah, blah, blah. So now you build a bit of a case with that. Financial concerns, alcohol and drug abuse, and numerous injuries to the same region. So all those things, and putting category for work, putting into your physical findings, your comorbid conditions, and then activities of daily living should give you a pretty good idea as you go along where you're going to go with this case, or if you're going all of a sudden hit the abyss. So now we're going to go, Dale's going to talk about a case study, and we'll get into the case studies now, and then, so this will sort of give you an idea of where the pitfalls are.
So as you can see by the presentation as we're going through this, none of this information is like it's out there. We all understand it, and we just intuitively know when after we've treated enough clients that these are the pitfalls we're looking for. These are the issues that we're looking for. But I think we also all realize that, as Gord mentioned, that, oh, you're treating somebody, they're coming along fairly well, you got a good rapport with them, then they get a little bit worse, and then you change something, and they get better for a while, and then they get worse again, and you just, before you know it, you're into this for 3, 4, 5, 6 months, and you still know I can get this person better. I just know I can get them better. If we just take a step back and look at some of the basic information, we maybe say to ourselves, well, hold it, maybe we need another look at this. And that's what we're just trying to do with some of these case studies, is just look at the basic information that we put on those progress reports and say, when we get rid of all the fluff, if that's what we want to say, if we want to get rid of all the chaff and just look at what's really lying there, some of the basic information can give us direction to the case management of the file. So this particular case study that I'm going to present to you is actually, it was a 27-year-old scaffolder. He fell approximately 40 to 50 feet, was found unconscious. The result of his fall was multiple injuries that we'll get into as we go forth a little bit. But when we look at the claim on file, what was accepted was the claim was accepted for back, neck, and knee injury. Now, the claim gets accepted from the WCB point of view from the information that is typically presented in the first while following the injury, the initial assessment from the physician, the initial assessment or the initial information gathered from the injured worker, if they can discuss with them, and the information gathered from the employer. All that kind of information comes together to give us what was problematic. What we see sometimes is, if we go back to those initial claims and those what it was accepted for, some of the problem cases start to expand. There's more things being treated. There's more issues going on. Now, sometimes those issues are relevant and they've been missed at the front end, but oftentimes it just gives us a direction that this is going to be more of a complex case. So this was a 27-year-old, fell down, had multiple injuries. The claim was accepted for back, neck, and knee injuries. He ended up at the hospital. Obviously, it was an emergency situation in the hospital, just summarizing some of the information from the hospital documentation. He had a full trauma screen with x-rays and CT scans, and these diagnostics included the shoulder and the knee. The x-rays from the knee and the shoulder were found to be normal during the initial course in the hospital. The major findings that when this injured worker was in hospital, and what were treated most specifically, were fractures involving the cervical and thoracic spine. Turned out to be left facet process and transverse process fractures at the C6 level. T3 to T7, again, transverse process fractures. And at T6 and 7, there were compression fractures noted. So, the length of hospital stay was 5 days, and the client was discharged with an Aspen collar and was to follow up with the neurosurgeon who was consulted within the hospital. So let us know if that double talk and echo is gone again. We've just rearranged some things here. So it was doing well for a while and then came back. So hopefully it's settled down again. From a physiotherapy point of view, the initial assessment was done 15 days after the injury. The diagnosis listed on this initial assessment was cervical and thoracic fracture, which would make sense because that's what the client came out of the hospital with. The objective findings discussed on that initial assessment was tenderness to palpation along the cervical and thoracic spine with muscle guarding. The neurological examination was unremarkable, but there was no assessment done on the articular condition of the spine, and that was due to the acuteness, or the information on file indicated that was due to the acuteness of the injury and the initial assessment. So the assessment of recovery score was 9 out of 10. Now I think that this was listed backwards, if that's what I want to say, as we'll see as we go through here. I think that they were listing here what they predicted that person would get back to. The intensity score was 1, so right off the bat they felt that this was going to be a difficult case. The Roland Morris was 22, and the NDI was 42. Now I'm assuming that NDI was 42 out of 50 with a raw score. So again, if we think back to the summaries of our different profiles, we got a high intensity score of 1, we got a high self-reported functional outcome measure, and we don't have a lot of quantitative information on the objective findings. The frequency of treatment at this point was 3 times per week, and they felt it was going to be greater than 8 weeks. So the first physical or PTP was about 1 month later. Now the diagnosis was fractures, multiple body parts, which was similar to the last, but also we now had a traumatic injury to the shoulder, including dislocation. The objective findings were positive AC joint separation, but there was no indication of what they meant by this. There was no description of a step formation. There was no indication that this was noted on X-ray findings. They just suddenly appeared on the report that there was a positive AC joint separation. So if we go back again to our summaries and our thoughts, we're already starting to see, more areas of concern coming in. We were dealing with the thoracic and cervical spine. Now we have a shoulder joint problem. Again, there's just tenderness along the T and C spine with muscle guarding, improved muscle tension and improved active range of motion, but no quantitative measures to let us know how improved this is, how well this person is coming along. We understand that this is only 6 weeks or so after fracture, so we're not expecting them to fit right into the soft tissue guidelines, but we can start to see the points that are coming out here. The assessment of recovery score now is 6 out of 10, which was 9 out of 10 initially. So the self-reported outcome score, 14, with the NDI of 24. Those are good improvements in the self-reported outcome measure. So that would tell us, we would anticipate, that the client thinks that they're getting better. There's been no contact with the employer about return to work options. There was none on the initial assessment, and there was none on the first PTP. And the only comments and explanation for this was he is unable at the moment. Again, no quantitative information about this. It should be noted that the client is following up with the neurosurgeon at this point in time. I don't know from the information on file whether the physiotherapist understood this, the treating therapist, but at this point in time, the neurosurgeon was going to start to wean them off the collar. 1 month later again, so now this is 2.5 months or so from the injury. The objective findings, no quantitative information. Improved CT spine range of motion, improving posture and alignment. First mention at all about whether posture was involved. Decreased tenderness and muscle guarding, much improved muscle tightness, able to tolerate manual therapy, full right shoulder range of motion, nearing full strength, and tender along AC. So intuitively, as you read this, you're saying this person is getting better. They should be. Everything is talking about being improved. Now the assessment of recovery score is 7 out of 10, which was 6 out of 10 on the last one, 9 out of 10 on the initial assessment. So really not changing drastically. So that would tell us that the practitioner's impression is that this person isn't drastically improving. The outcome measure score, though, from the client themselves is now down to 15 on the Roland Morris, which started at 22. That's improvement, but it hasn't changed from the last report to this report. And the frequency of treatment has not changed. Gord talked about individualizing treatment, and the soft tissue guidelines talk about individualized treatment at different stages in the soft tissue healing. Well, we're still going 3 times per week, and we still think it's going to be more than 8 weeks, and still no return to work. So that component of getting somebody back to their normal activities hasn't been addressed as yet. 2 weeks later, which would be right around 3 months post-surgery, the neurosurgeon discharged the client from care. All the fractures were well healed, and there was no indication for surgery. The PTP, about 3.5 months after, assessment of recovery score is still same. Self-report measure is now down to 12, which has improved somewhat from the Roland Morris. Still at 21, down to 21 with the NDI, which was 42 when we started. So again, good improvement. This should be telling us that client feels they're getting better. Their perception is they're improving all along. The objective findings are still talking about improvement, but just talking about it, more qualitative information. But there's still no return to work, no contact with the employer, no discussion with the employee about returning to work. So, if you, again, hindsight is 20/20, as they say, but we're just trying to point out the components within the process and with just looking at the progress reports, which may give us an indication that something is not going in the direction we'd like to. The objective findings are improving, we think, apparently by the information used. The assessment of recovery score is not changing, so the practitioner doesn't really identify that this person is getting better. The self-assessment functional outcome measure score is improving, but there's no return to work discussion and the treatment is the same. So these are starting to part. The components are starting to part. 2 months later, same assessment of recovery score. Self-report went from 12 to 9, 21 to 17. Objective findings are now talking about pain to palpation and tight muscles. No concrete objective findings noted with numbers. Suggested at this point a work hardening program for 1 to 2 months. However, there's no contact with the employer, no return to work discussions, no job inventory worksheet on the file, or no discussion about what the job components would be, and the frequency and duration of treatment is still the same. So if you look at that again, we're getting better, yeah, we got to condition them, but we don't know how far we're going to condition them to. You can just see how things are just separating a little bit. So at this time, there was a consultant review done. It said, you know, the client's, by all intents and purposes, getting better. We should incorporate a return to work plan, or if that's not forthcoming, then we should have an assessment team review. So the assessment team review did occur. There was a referral on to higher level treatment programming, and a multidisciplinary treatment occurred. Following the assessment team review, the treatment plan now from the primary level care was simply, we'll keep doing what we're doing until the patient goes on to secondary or tertiary. Now, I'm not trying to point out that, you know, poor treatment or whatever. What we're trying to do here is just take components of the progress reports, components of the case file, and identify how the management of this case, how it could go down a different path, how when you get to certain forks in the road, if we just take a step back and look at the hardcore information that we're providing, does that give us a direction of what to do with this client? So in summary, this client is still not back at work. He is presently with vocational rehab services. His actual problem is with the shoulder, is what he ended up going through voc rehab services for. He ended up having surgery on the shoulder. the claim, when you go through the whole claim, certainly did not follow typical guidelines. It was not a soft tissue injury. There was a fracture. And at certain points, both WCB, there was no consultant review till 6 months. There could have been things that were done better on all sides. But again, as I had identified, we're trying to illustrate that there's different components of the findings that were present, that there's things that weren't changing, and there certainly could have been multidisciplinary assessment done a long time before, probably 2 to 3 months before at least. One of the major components, as I reviewed this file, that I thought was the return to work. And although sometimes we're feared, if that's the way we want to talk about it, of return to work, or we're trying to not push the client back, we need to get them better. If we think about that return to work as a proxy for getting back to normal activities, as a test event or a test project to how are they going to manage in their normal activities. In this case, I think if the person could have gotten back to work in a sooner time frame, the problem with the shoulder would have certainly come forth in a much sooner time frame, and could have been hopefully addressed sooner. And therefore, this client, like I said, I think it was 2010 was the injury date. He's still not returned to work. Based on the research, very difficult now to get this person back into the workplace full go. So that's that one. There's one case study for you, and now Gord's going to go through another case study to try and identify or just point out some of the areas where we can hopefully look to progress and manage our cases better.
Okay, before we do the case study number 2, I want everybody to stand up and stretch because I'm getting stiff. We've been sitting here for an hour. So everybody get up and stretch because we should walk the talk. And if we're going to suggest get up and move around, we should do it ourselves. And same with exercise and same with nutrition.
I got
That's
okay.
We're going to go for lunch.
Okay. So this is the second case study, and just give you a bit of the profile of this injured worker. She's a female service worker, works in the hospital. The date of injury was 2009. She's 47 years old. She's 5 foot 4 inch, 218 pounds. She has a pretty high BMI. Low fitness level. She doesn't really do much activity at all. She's been with the worker for 12 years. Number of WCB injuries, 14. Time loss claims, 11. Number of injuries to the same area, 3. And currently has a second WCB claim for left wrist tenosynovitis. Pain intensity score, intensity initial on program actually wasn't put on the CHI or the PTI initially. So the assessment of recovery on the initial exam by the care provider was 2. The intensity score was left blank. There was nothing there. Roland Morris was 9. And obviously there's no job satisfaction. And marital status, married, high cholesterol. She's off work right now, and modified duties are available for her. So she saw the chiropractor initially. Her main symptoms were central low back pain radiating into the left leg. Examination findings, range of motion was 12 inches from the floor. So she had, that's all that the examination findings stated on the report, is 12 inches from the floor. No idea about the other ranges, but she obviously has fairly good flexion. Straight leg raise was 45 degrees, and it was bilateral, but really no indication was there leg pain. There was no other neurological findings. There was mention that it couldn't elicit the plantars bilaterally. So the diagnostics, x-rays were taken, and there was moderate degenerative changes at 2-3 and L5-S1. this person had a bone scan, and the bone scan was booked earlier, and it appears it was booked by her family doctor, not necessarily for the back pain, although it looks as if she had some concern. There was no cancer that she put down on in the medical history, but somehow the physician must have decided that he was going to do a bone scan, whether it's because of her wrist or now the back pain, or she's had multiple back problems, but he did a bone scan and it was normal anyway. No, the CHP comes back 8 weeks later, and the assessment of recovery is at 3 to 4 out of 10. Her Roland Morris now is at 11. Tried to return to work for 2 days. She exacerbated her pain and then ended up off work again. And then the chiro decided, okay, well, I'm going to refer to physio and sort of see if a dual program will help the situation. So the PTI comes back approximately 3 weeks later after referral by the chiropractor, and range of motion restriction of flexion is 25%. There's positive kinetic testing. Neurological is still clear, nothing. Piriformis gluteal muscle hypertonicity, and now the Roland Morris is at 12. And the diagnosis is lumbar disc pathology, but there's no neurological findings, and really just restriction of forward flexion, and really no reason to say why this is a lumbar disc pathology at the time. And they did discuss a return to work. There was a consultation with the orthopedic surgeon in November, and this was for her bilateral epicondylitis, and the orthopedic surgeon recommended further physiotherapy. So the CHP, the next in November, assessment of recovery is 4, very slow progress, not a lot of physical findings, no neurological findings at this point, and this is a slow progress of somebody who has back pain. So she continues on return to work, but is still on modified duties, and she's not back to full hours yet. The PPP from her family physician comes back. There's not much on the family physician's report. Pretty scant back pain, still complaining of back pain, didn't mention any leg pain at all. He rates her recovery at 6 out of 10. It goes to January, and the physio report now says, still on modified duties, not back to regular hours. The assessment of recovery is 7, but now her Roland Morris now is at 19. And all of a sudden, we're getting neurological findings, positive straight leg raise. She's got an S1 weakness, a decreased reflex, S1 reflex, and all of a sudden now it's sort of, okay, we better send it to a multidisciplinary. Gets to the multidisciplinary January 15th. She's still not back at work, or just on very light modified duties, not regular hours. And the MDA diagnosis is grade 2 low back pain. Their exam found limited range of motion in both flexion and extension, but straight leg raise was fairly normal, 70 to 80 degrees, no neural tension signs. Neurological exam was normal. So within less than 2-3 weeks, we got a positive neurological findings to no neurological findings. Tenderness and tightness in the paraspinals, piriformis in glutes, segmental hypomobility of the lumbar spine. So they identified from the psychology and from her the medical history that she was very pain focused. She continues to be on Dilaudid and ibuprofen at the same intensity that she had when she first started, had her injury in July and was prescribed by her family physician. She's very health anxious. She's worried about her wrist. She's worried about her other comorbid conditions, and she's catastrophizing. And this is based on the psychology report. She has sleep disturbance. She's not sleeping very well. She says her back pain wakes her up. She has an adversarial relationship with WCB. They've cut her off in other claims that she's had, time loss claims, and they've cut her off. And so she doesn't have a great relationship with WCB. And then she also has this elbow and wrist problem that she is now needs to be addressed. And she's had a history of, this is her third back injury, and she's had time loss claims from previous back problems. She's had 11 time loss claims. She now goes home, and according to the psychology report, she has to have her friends help clean her apartment because she can't do it because her back pain is so bad. We know that through her BMI, she's obese. She says that she basically reads a lot and watches movies. That she's not very active at all. Her Roland Morris now is at 15, so we started off very low at 7, I think it was, and then now we're at 15. It just progressively got worse as we got along, and the oswestry is 44%, and she rates her pain levels at 7 to 8 out of 10. So this case actually has gone completely the other direction. And so what did they recommend with the multi? So the tertiary treatment, 8 weeks. She needs a lot of pain management, some biomechanical treatment. Continue with manipulative therapy. She ended up going on to an MRI, and just not because the tertiary team recommended it, because they really didn't find any neurological findings, but her family doctor, because she kept on complaining and saying, oh, I'm just not getting better, decided to do an MRI and really found the same that they found on plain films, some moderate spondylosis of L2, L3, and L5S1, but there was no neurological, no disc findings, no lateral stenosis, or no effacement or nerve root involvement at all. The program was extended 10 weeks because of reports of pain. She gets back to work, return to work, and gets back onto full duty. She has a recurrence of her back pain, but this now brings us into practically June. So we've talked about this. Each individual case is different. I mean, each person coming in, we know that work-related injuries can be complex, and we need to be able to sort of ask the right questions so that you can sort of dissect what you need out of it to make a realistic plan. So this person, right from the get-go, should have been a 1, high intensity from the initial. And why is that? We look at the medical history, is that right from the beginning she was pain-focused. She was health anxious. She was sort of catastrophizing. She wasn't sleeping very well. She had an adversarial relationship with WCB. She had another outstanding claim, so that makes it complex too, because now we got 2 injuries. She's had a history of previous low back pain. She's had 11 time loss claims. And if we go into it, some of those time loss claims, actually she was, WCB had to discontinue their responsibility for it, not because she was necessarily better, but because they felt that it was mechanical back pain and then it needed to be ended. Her functional questionnaire score kept going up through the whole thing. So this has 2 comments to this, is that we get the chiropractor who basically does the right thing, does a functional questionnaire, puts it down. But the next CHP, the functional questionnaire starts to go up. Goes to the physio and it was appropriate referral because not getting better, but goes to the physio, and the physio has the functional questionnaire going up. Now the question is there any communication between the 2 of them to sort of go, well, what did they start off with and where are they at now? So the physical findings were very inconsistent. I mean, at one point we're finding not a lot of physical findings. There was some question whether there was some neuro at the very beginning, but really that didn't prove out later on when the person saw the chiropractor again, and they put the chiropractor put the CHP in there, and then really there wasn't any neurological findings to show that there was any nerve root involvement or anything significant. Goes to the physio. The physio also no neurological findings, but the examination findings are up and down, and we talked about that. The variability of physical findings in the course of the management plan. Poor understanding of her injury. I mean, when she came into and did the MDA, the psychologist states that she just really didn't understand what her injury was and why she was still not better, and that nobody had actually talked to her about her problem, which I find that hard to believe that far into the injury. And then she had obesity and she has a low activity level, which again is a bit of a flag. So these are two cases of what one pretty a significant injury that's prolonged, one a mechanical back pain that is prolonged, and some of these cases, if they go on for a year, we know that the chance of getting them back or having them their problem reoccur is high. So that's why oftentimes, we ask you to put the information on the report so that we can sort of follow along and sort of understand when maybe there's some inconsistencies between a physio report or a chiro report, or whether maybe you didn't catch that actually functionally that she was deteriorating, or that there's some other comorbid problems, or so putting down the proper information on the reports is important. And it's not just important for us, but I think it's important for you to go through the exercise of doing it, because once you start doing that, some of the questions that you should be asking yourself, you have to do just to fill in the information. Some of concerns is that oftentimes the reports don't really show good physical findings. And Dale has already talked about this, but I'd like to reiterate it, is that oftentimes when, and it's just not physio and chiro, physicians are worse oftentimes, but they just don't put down positive physical findings. If there's discogenic back pain, for that diagnosis, we should have neuro findings, some type of positive straight leg raise, positive slump, reflex sensory changes, something that's going to sort of verify what your diagnosis is. So I think that's part of the problem. We still have problems with what the recovery scale is. Some people still have that confused, that when they come into the office, is that when you ask them where would you rate your recovery at, and where do you think you are 0 to 10, 10 being fully recovered, oftentimes people are still getting, care providers are getting it flipped, that in fact it's the other way around. 10 is severe and 0 is nothing. And so please, it's, that's part of the things that we look at, so you want to make sure you get that right. And we want to make sure that we're progressing with the return to work. And we know that because the research clearly says that, hey, if you've got, especially with back pain, and it's mild to moderate, you're going to do a lot better if you're back at work than if you're just trying to keep them off work and just try to rehab them. The other thing is that it's really not great when you're, as a consultant, you're looking over a case and the initial doesn't even put down whether they've had a previous problem or not, and it's left blank. And this just gives us a heads up of what's going on, but you find out 3 months or 4 months later that in fact they had the same problem 2 months before they even presented to you. And then all of a sudden it comes into play. So please put down those are important parts of the CHI and CHP.
So when we've been discussing these today and going through the cases, we've obviously been trying to focus on the different information, the progress reports, the initial assessment reports, and really I think that Gord touched on a very good point there is, and we don't know, we can't tell specifically from the case that we reviewed, but the communication, was there communication in that scenario between the chiropractor and the physiotherapist with that referral? That's just an example. I think the big word there is communication. And we try to, like I mentioned before, we consciously set up the progress reports and the initial assessment reports to try and get information to allow that communication to occur, and so that we're all talking the same types of languages. And as we, of course, as consultants, we would see probably, I'm just guessing here, 8 out of 10, 9 out of 10 of the complicated file. If there's an easy file that runs through the system and everything goes perfect, and we don't ever see it, and it doesn't get to any level where we can review it, and that's just an indication that the majority of our clients that go through the system we don't ever see because of the job that you guys are doing out there and the way that you're managing the majority of them. The ones that we get to see, the similar pattern comes up. The similar pattern in regards to there's not, solid objective findings. There's not a recognition that there's been some kind of return to work involvement or some type of a return to work attempt. There's not there's no information or recognition that the numbers have been looked at, we see when we look through the file that the functional or the self-reported outcome isn't changing, or the assessment of recovery isn't changing, and the treatment plan is still the same, on and on and on. Well, that makes us wonder, well, hold it, have they just stepped back? Has that practitioner just taken a step back and said, things aren't going the way they should here? And that's the big, I think, take-home message that we're trying to put forth in the complicated case. If we do good documentation, if we just fill out the information that we have some milestones, we have some signposts to go back to take a look and say, are we really progressing with this client, or do we need more resources? And that's what the system tries to do. It tries to identify those and move them on to the assessment team review to give them more resources to recover. And the quicker we can identify that and provide them with those resources, the better outcome we would hope to have. So the screen up there now is questions. I haven't seen anything come up on the chat. We'll blabber on here for a few more minutes to see if something comes up on the chat, and if not, we'll close our webinar with all that have attended, and thank you very much for attending.
Yeah. Just like to remind you that most of the information we're talking about, soft tissue guidelines, and is on our website. So make sure you go to the website, take a look, scan through it. A lot of what we're talking about is on there, and so you should try to go through that because it'll probably answer a lot of your questions. Any questions at all?
Yeah.
Are you all falling asleep, or should I play the stress tape again, which is my favorite?
Thank you, everybody, for attending, for taking a couple hours out of the middle of your day. We certainly welcome any feedback, whether you just email it all straight to Chris or show up at her door all together one afternoon. No, don't do that. But or even send to us consultants. Do you like this format? Do you like the webinar in the afternoon? Do Do you, like the mid-afternoon here on a Thursday versus an afternoon, whichever?
Can they claim this CME, Chris?
Yes, we'll send the list to the Chiropractors Association.
This isn't the chiro,
This is a physician, I think.
it's physician.
Physician?
I think the answer is probably not.
Probably not, unfortunately with CME, because you have to register with the college first of all, and then identify who your speakers are, and that has to be then, credited by the college itself before you can do CME hours. But, I mean, if there's more physicians who are interested in joining the webinar, we'll definitely, approach them and see if they could get CME hours, because I think it's definitely, this is the way to go. It just doesn't disrupt your practice.
Well, thank you very much, everybody, and we'll talk to you at the next webinar. And if you're missing us, just launch into the website and hang out with us for a couple hours while it'll be up there for the next couple of years. Thanks a lot.
Okay, thank you.
Thanks.